Welcome to the ACOM Public Policy Briefing Conference Call. My name is Larissa, and I'll be the operator for today's call. At this time, all participants are in a listen-only mode. Later, we'll conduct a question-and-answer session. Please note that this conference is being recorded. And I'll turn the call over to Barry Eisenberg. Mr. Eisenberg, you may begin.
Thank you, and good afternoon, everyone. My name is Barry Eisenberg. I'm the Executive Director of ACOM, and it's my pleasure to welcome you to this public policy briefing. This is the sixth in our series of public policy briefings for 2013, and we're delighted to be able to provide those to you as a feature of your membership in ACOM. Joining me here at our headquarters in sunny Oak Grove Village this afternoon are Miles Hoffman and Dana Kelly, who helped organize this public policy briefing. I want to thank both of them for arranging that for us. We're also fortunate today to have Pat O'Connor joining us. Pat O'Connor, as many of you know, is our Director of Government Affairs. This is Pat's third public policy briefing that he'll be providing for us in this calendar year of 2013. As was mentioned earlier, this program is being recorded, and for those of you who aren't able to stay for the entire hour or want to view it again, it'll be posted hopefully sometime later today on the ACOM's Idea Marketplace under the health policy topic. So with that brief introduction, let me turn it over to Pat.
Thank you very much, Barry, and let me also extend a welcome to you folks for joining in this public policy briefing. I am ACOM's Director of Government Affairs. I am based in Washington, D.C., which sometimes is good news and sometimes is bad news. We sometimes refer to ourselves as Disneyland East here in the Washington, D.C. area. Brief overview of what we will cover, or what we'll cover over the next 40-45 minutes. I'm going to touch on the election, talk a little bit about the Fiscal Cliff, an issue that is getting a lot of attention, at least in Washington, D.C. and in the national media. Talk about where things stand with the Affordable Care Act and where we'll be going with the Affordable Care Act in 2013, 2014, and beyond. And then spend some time talking about the outlook for 2013, what we can expect and not expect in the next year. And then, assuming time permits, and I'm sure it will, we'll have questions and answers at the end of the web briefing. In addition, I will have my contact information on here, so please feel free to contact me if you have questions about anything that comes up in this public policy briefing or other issues of interest to you and to occupational medicine. To talk about the election, of course, we know that we still have a divided government. We have a Democratic president, we have a Republican-controlled House of Representatives, and a Democratic-controlled U.S. Senate. So divided government will continue as it has for the last 2 years. This is not necessarily good news for occupational medicine and for public health. If the bipartisan atmosphere continues here at the federal level, it will be very difficult for the Congress or the administration to get much done in the next 2 years. Unfortunately, a lot of the issues that are important of importance to occupational medicine and to public health will get pushed to the side as the bipartisan or lack of bipartisanship would continue here in Washington, D.C. I hate to be a pessimist, but I fear that might indeed be the case. The election impact, with respect to the Affordable Care Act, the President Obama was reelected, and the Affordable Care Act will move forward. The House of Representatives will make an effort to repeal portions of the Affordable Care Act, but their ability to do that is going to be thwarted by the Democratic Senate and, of course, by the President himself. The state network exchanges that I'll talk about a little more in detail in a few minutes will go forward. Accountable care organizations, a health delivery model that has come out of the Affordable Care Act, the ACO model will continue. The investment in prevention. There is a public health and prevention trust fund I think the election still puts the future of that trust fund in some jeopardy. The Republican leadership in the Congress would like to deplete the funding that has been authorized for the Public Health and Prevention Trust Fund. There have been several efforts made over the last year to deplete that fund. It is a trust fund, so it's not subject to the traditional congressional appropriations process. It's several $1 billion that's authorized by the Affordable Care Act. Of course, you can repeal or amend that authorization, and that is what's been tried with limited success in the last year. But I think, again, the investment in prevention will be in some jeopardy. Wellness incentives, fortunately, we see both Democrat and Republican support for the wellness incentives that are embedded in the Affordable Care Act, so those should move forward. And again, as I mentioned, the Prevention and Public Health Trust Fund will continue to be in jeopardy. Tax reform, there are talks about significant tax reform in 2013, and one of the issues that may be on the table, and I will provide a little more information on this shortly, is the status of employer-provided health insurance. Major tax reform will need major sources of revenue, and one of those major sources comes from the employer-provided health insurance revenue source. The other is federal spending. There's no question that our government is in a fiscal dilemma. Federal spending will be reduced in the next year. It will start with the fiscal cliff that we'll talk about shortly and continue into 2013 as we get into federal spending programs. We need to expect that there will be budget reductions in programs that are of importance to occupational medicine and to prevention and public health in 2013. And that's simply because all of discretionary spending throughout the federal government is going to be subject to budget cuts. And although we will make the case to retain and, in fact, increase some of the spending programs of importance to occupational medicine, in doing that, we will be in competition with others who are seeking additional funding for NIH programs, for research programs, etc. The fiscal cliff. As we talk here today, we would hope that the White House and the congressional leadership are working on trying to resolve the fiscal cliff. What is the fiscal cliff? Here's a very simple look at it. If nothing is done between now and December 31st, there will be tax increases of $380 billion. That's because there's a number of tax provisions that expire on December 31st. In addition, there will be spending cuts of $100 billion. Those spending cuts have to be made beginning on January 2nd. The fiscal cliff taxes, what would expire on December 31st include the 2001-2003 tax rates, including individual tax rates going up, state tax rates going up, investment income rates on dividends and capital gains, those will go up, as will the child tax credit, etc. There's also some other expirations on December 31st. There was some stimulus tax credits in the 2009 stimulus bill, the payroll tax holiday, where we all enjoyed a reduction in the FICA tax we pay, alternative minimum tax, and a host of tax extenders. All this happens on December 31st if there's no action by the Congress and the White House. A snapshot of the effect of just the tax provisions. Lowest wage earners would see an increase in their tax bill of between $400 and $1,200. Middle earners would see an impact in their tax bill of between $2,000 and $3,500, with the highest earners seeing $14,000 and more in increased taxes. The impact on the economy and on the individual is that these tax cuts will be seen in the first paycheck that you and I receive in January. So these are not phantom tax increases. These are tax increases that would be reflected in the withholding schedules that affect yours and my paychecks. The sequester, and this is to many people the more serious issue, there are budget cuts under sequestration that were built into a 2011 agreement to raise the debt ceiling. These cuts that were agreed to in 2011 are designed to force a super committee of lawmakers to agree on $1.2 trillion in spending cuts over 10 years. That super committee failed to do its job. As a result, come January 2nd, there will be across-the-board spending cuts of 7.6 to 9.6% in all discretionary spending. Those spending cuts in 2013 have to be applied to every single federal program. In 2013, federal agency heads have no leeway to adjust those spending cuts between programs. The impact of that, we would see a several $100 billion cut to CDC, for example, cuts in OSHA enforcement, cuts at EPA, et cetera. Again, the implications of this is that they're across the board, which means every program will suffer. And the cuts are evenly divided between defense and non-defense discretionary spending. The net impact, and that's why you may be reading or hearing that the economists and the markets are very concerned, is projected impact in 2013 would be a 3.5% decrease in the gross national product. We would see the U.S. credit rating downgraded, increase in unemployment, et cetera. That's why Congress is so focused on the fiscal cliff and focused on little else. What does this mean going forward? What's going to happen in 2013? We're going to see the first 6 years of 2013 focused almost exclusively on fiscal issues. Other issues of importance to occupational medicine will be on the sidelines as far as Congress is concerned. Some do expect the fiscal cliff issues will be resolved by New Year's, but that Congress will have to come back in the first week of the new year to dot the I's and cross the T's. Come February, we are currently working on a continuing resolution to fund the federal government. That continuing resolution expires on March 31st. So when we get into the February-March timeframe, Congress again will be wrestling with how it funds the federal government and federal programs. That will be followed by a substantive look at entitlement reform, tax reform, et cetera, in the July-August timeframe. So as you can see, most of what Congress and the White House will be doing in 2013 is going to be devoted to fiscal issues. That being said, I guess I'm going the wrong direction here. Sorry about that. Apologize about that. That being said, the Affordable Care Act will continue to be implemented because implementation of the Affordable Care Act rests with the federal agencies, primarily the Department of Health and Human Services. As I said earlier, the Affordable Care Act is here to stay. The Supreme Court did rule that the individual mandate was constitutional, and the vote in the November elections returned the president to the White House. So the Affordable Care Act is a fact, and now employers, occupational physicians, and et cetera, need to look at how the act will be implemented. What's ahead for 2013? There will be a $2,500 limit for employees being able to put pre-tax dollars into flexible spending accounts. Employers will not be limited on the amounts of money they could put into an employee FSA, but employees would be limited. Employers will have to disclose on the employee's W-2 the cost of employer-provided health insurance that was provided in the 2012 tax year. Although the value of that employer-provided health insurance would not be taxable, employees will have to have that reported on their W-2. 100% of women's preventive care will be required in 2013. In addition, there will be a notification requirement that beginning March 1st of 2013, where employers must notify all current employees and new hires of the availability of state health insurance exchanges, and including information on whether or not the employer's plan covers 60% of the cost of care, and if not, that the employee may be eligible for a premium subsidy or cost-sharing reduction. The issue of what 60% is equivalent to is still being worked on by the Department of Health and Human Services. In 2014, the health care exchanges are to be up and running. The individual mandate for coverage takes effect in 2014. There will be the employer will face play or pay penalties. In addition, employers may face play and pay penalties, which I'll talk about in a second. In addition, employers with more than 200 employees and who offer health coverage must automatically enroll new hires after a waiting period. There will be an opt-out where a new hire would be able to opt out of the Affordable Care Act or the employer-provided health insurance, excuse me. There's a lot going on, though, to make all of this happen. First are the state health care exchanges. States have the option to set up a health insurance exchange. These are online marketplaces where individuals and small businesses can shop for a private health plan. Each state is empowered to devise its own benchmark plan subject to broad federal guidelines. Those benchmark plans then will have to be met by any insurance carrier who wants to provide its product on a state insurance exchange. States then will have the option to expand their exchange to large employers beginning in 2017. States do not have to, however, set up a state exchange. They have the option of either partnering with the federal government to set up an exchange, or they can opt not to do an exchange at all. In that case, it would turn to the federal government to offer the exchange in the state. These exchanges have to be up and running by January 1st, 2014. Individuals have to have the option to sign up with the exchange beginning October 1st of this year, of 2013. As you can see, though, those deadlines are awfully ambitious considering that we're just at the end of 2012. Most states have yet to make the decision on what they want to do on a state health care exchange, whether they're going to do an exchange or not. This is the week that the states are to notify HHS of their decision. As part of the state health care exchange, health plans have to provide a core package of items and services. These are known as essential health benefits. States will be given wide latitude to decide what essential benefits insurers must provide in their health policies, as long as they offer items and services in 10 broad categories. One of those broad categories is preventive and wellness services and chronic disease management. A health plan that's offered on an exchange has to ensure coverage of preventive services that are rated A and B by the U.S. Preventive Services Task Force. So any plan offered on a health exchange or offered in a small group market will have to provide preventive and wellness services. HHS, Department of Health and Human Services, issued a proposed rule providing some definition as to what this means this past November. Comments in that proposed rule are due by the end of this month. So the states and the health insurers are still struggling a bit as to what it means with respect to the 10 categories of essential health benefits and, of course, what the preventive and wellness services will have to be. In 2014 are when the employer requirements go into place, and many employers are today making the decisions or looking into the decisions that have to be made come 2014. First, there's a play or pay requirement. Certain employers who have more than 50 full-time workers that do not offer health insurance will have to pay $2,000 per employee penalty. Now, there's some math involved in this. You would take your total number of employees, subtract out 30, and for the life of me, I don't know what the magic is to the number 30. But you take your total number of employees minus 30, and if at least one employee is eligible for a premium subsidy, and a premium subsidy is basically will be available to anybody whose income is less than 400% of the poverty level. If one of your employees is eligible for a premium subsidy through an exchange, the employer will pay a $2,000 penalty per employee. That's the play or pay. There's also a play and pay provision, and this is for employers who offer coverage, but that coverage is not adequate or not affordable, and have at least one full-time employee who opts to go into the exchange and receives a premium subsidy will pay a penalty too, and this penalty is the lesser of $3,000 for each employee who receives that subsidy, or $2,000 for each full-time employee, again excluding the first 30. So this is what employers are looking at today, is what these penalties mean. Will it be cheaper to stop providing health insurance and opt to pay the penalties? What are employer options going to be? So a lot of employers that I've talked to are seriously considering what their options are come 2014. Looking down the road, in 2018, we have what are called Cadillac plans. This would be an excise tax on employer-provided health plans that provide coverage that exceeds a certain threshold. The threshold right now would be $10,000 plus for individual coverage, or $25,000 plus for family coverage. The Cadillac plan excise tax goes into effect January 1st, 2018. The use of the term Cadillac refers to the fact that Cadillacs used to be the luxury vehicle in the United States. Although it's still a luxury vehicle, there are many other luxury vehicles in this category. I had a question recently about why the term Cadillac was used, and it came from a person who wasn't familiar with the fact that Cadillac used to be the luxury vehicle in the United States. There was not a lot of activity from the administration in the Department of Health and Human Services prior to the election. Since the election, HHS has been regularly releasing proposed rules with respect to the Affordable Care Act. And I'll just in the next couple slides go through with you some of these rules that have been issued in the last month. There's a proposal for employers that offer their workers wellness programs, and I'll talk a little bit more about that in a second. There's a proposal on health insurance reforms that spell out how the Affordable Care Act will apply to issues like ban on limiting pre-existing health conditions, how insurers can vary premium prices on the basis of age, tobacco use, etc. There's also the proposed rule that I mentioned outlining policies and standards for coverage of essential health benefits. These, again, are proposed rules. In a proposed rule stage, stakeholders can submit comments to the Department of Health and Human Services. HHS will review those comments and then issue a final rule. Those final rules will be issued sometime in the 2013 time frame. On November 30, the Department of Health and Human Services issued a couple of new rules. One would deal with employers or multi-state health plans where an employer has facilities in multiple states. There is a requirement that employer plans or multi-state plans follow what's called an essential health benefit benchmark plan. Each state sets its benchmark plan. The November 30 rulemaking would allow an employer to either choose to follow a benchmark plan in the states it operates, or to use a benchmark plan chosen by the Federal Office of Personnel Management, and that would be a benchmark plan that's based on one of the 3 largest federal employee health plan options. They also issued a proposal that sets a fee that all payers, including employers who self-insure, must contribute towards the health law's temporary reinsurance program. This is a fee of $63 per employee per year. This money will go into a fund that will help balance out the requirements in the individual market, where insurers no longer will be able to ban pre-existing conditions, etc. My understanding is that this $63 per person fee will go into this fund and be used to help keep down insurance rates in the individual market. Last week, on December 5th, the Internal Revenue Service issued a final rule that sets a 2.3% excise tax on the sale of most medical devices. These medical devices will include x-ray machines, medical equipment that you may use in your practice. It can include software that you may use. So come January 1, you are going to see an increase in your cost on products you purchase from a manufacturer, and that excise tax is 2.3%. That excise tax does go into effect on January 1st. It is a final rule, so there is no leeway. So you probably will see increase in your cost for equipment and devices come January 1. Again, I mentioned multi-state employer plans. The government is proposing by rule a choice in the benefit packages that a multi-state plan can offer. You can opt to either follow the state's essential benefits benchmark plan in the state where you're operating, or follow the benchmark plan chosen by the Federal Office of Personnel Management. This was seen by some in the employer community as a positive result. Incentives, wellness incentives. This is an area where ACOEM has been spending a lot of time during the debate on the Affordable Care Act and now during the implementation of the Affordable Care Act. The proposed rule that was issued in November builds on the existing incentives that employers have in federal law to encourage opportunities for employees to engage in wellness programs, and as a result, encourage healthier workplaces. What it does, what the proposed rule does, it increases the maximum permissible reward under a health contingent wellness program from 20% of the cost of health coverage to 30% of that cost of coverage, and increases the maximum reward up to 50% for programs that are designed to prevent or reduce tobacco use. Again, this proposed rule was issued on November 20th and would be effective for plan years starting on or after January 1st, 2014. Again, under current law, an employer can provide a 20% reward, rebate, reimbursement, whatever you want to call it, against the cost of individual health coverage. That amount will now increase to 30% come 2014. There are two types of wellness programs. There are what are called participatory wellness programs. They are generally available without regard to an individual's health status. Examples here include reimbursing an employee for the cost of membership in a fitness center, providing a reward to an employee for attending a monthly no-cost health education seminar, etc. These are participatory wellness programs where there's no requirement for the employee to meet a health outcome. There's no limit on what the employer can provide in the way of a financial subsidy for these participatory wellness programs. At the same time, some of the rewards that may be provided would still be subject to taxation under Internal Revenue Service rules. The other one, and more importantly, the one of most interest, is the health contingent wellness programs. And this is health contingent wellness programs are wellness programs that meet a specific health outcome. These programs will generally require individuals to meet a specific standard related to their health to obtain the reward. Examples here would include programs that reward an individual who either does not use tobacco or decreases their use of tobacco, individuals who meet a specific cholesterol level, weight level, etc. These are health contingent wellness programs. The proposed rule in the Affordable Care Act would allow an employer to provide a reward of 30% of the cost of individual coverage for participating in a health contingent wellness program and meeting a certain health outcome. Those programs can be available to dependents also, and when that happens, the amount of the reward would be 30% of the cost of family coverage. There is some question about how that will work, particularly because there is a provision in the proposal and in the rule that in the law that these health contingent wellness programs must be reasonably designed to promote health and prevent disease, be reasonably designed to be available to all similarly situated individuals, and to provide notice of opportunity to qualify for the same reward through other means. This through other means has been expanded to say that if an individual is unable to meet a specific health outcome, they have to be given another chance to meet that outcome. That is fairly easy to deal with for the employee. But when you're dealing with dependents, it's how do you modify a program if the dependent has failed to meet a specific health outcome for which a reward has been offered or provided. ACOM was very pleased that the proposed rule adopted many of the recommendations that were included in a consensus statement that ACOM was instrumental in developing over the last year. And that consensus statement on employer-based wellness programs was published in the July edition of the Journal of Occupational and Environmental Medicine. ACOM is now working with our partners who helped develop that consensus statement to develop comments on the proposed rule. The partners that we're working with include HERO, American Cancer Society, American Diabetes Association, the American Heart Association. Excuse me. Switching from the Affordable Care Act to the outlook for 2013 in other areas that may be of interest to you, I want to touch on a couple of things. Tax reform. This slide, I apologize, is a little difficult to read, but I just wanted to bring this to your attention again. When you look at the number of tax deductions that are available right now under the current tax code, you'll see that in exclusion of employer contributions for medical insurance premium and medical care is the single largest revenue loser to the federal treasury. So $131 billion a year is the cost of excluding employer-provided health insurance. Again, you'll see from this chart, it's the single largest item on the list. We just have to be cognizant of the fact that if Congress gets into tax reform in 2013, this will be an issue that will at least be discussed So I just wanted to make sure that the folks on this briefing were aware of that. OEM residency funding. ACOM is actively looking at legislative options to increase federal funding for occupational medicine residency programs. We are working on making sure that funding for the NIOSH-sponsored ERC residency programs is continued, and we would hope that that funding could be increased, but we know in this current fiscal climate increases could be difficult. HRSA funding. HRSA provides funding for residency programs in preventive medicine. ACOM was successful in the last couple of years in getting that HRSA funding made available also for occupational medicine residency programs. ACOM is working on a survey that is referred to as the Footprint of Occupational Medicine. This is a survey that will be coming out in the next few weeks that you folks on this call may receive the survey and be asked to respond to it. What we're trying to do here is to better quantify the reach that occupational physicians have throughout the healthcare system. To use this as a foundation for making the case that not only is additional funding needed for OcMed residency programs, but more residents are needed and more physicians are needed in occupational medicine. We're also looking at the role of population management in occupational medicine in bending the Medicare cost curve. Medicare will be one of the entitlement programs where Congress and the White House will be taking a close look in 2013. With the aging workforce, occupational medicine has a real role in, as we say, graduating healthier workers into the Medicare program. Last item there is Institute of Medicine has a study underway of the funding and governance of the graduate medical education program. As you know, right now, OcMed residency programs generally are not eligible for GME funding that's provided by the Centers for Medicare and Medicaid Services. The IOM has been asked to do a complete review of the GME program. ACOM's president, Carl Auerbach, has been invited to make a presentation to the IOM committee here in D.C. next week. This is a great opportunity for ACOM to talk more about the expanding role of occupational medicine and occupational physicians in the nation's health system. Switching to an unrelated item is fracking. Fracking is certainly one of the major environmental issues of this year and next year. ACOM has sent a letter of support to NIOSH. NIOSH is undertaking a major research project into the occupational implications of fracking. This research, ACOM feels, is very important to, again, kind of set the foundation for what we know and don't know about the occupational exposures that are associated with fracking. Opioids, this is a major concern at the state level and the federal level, the overuse of opioids, the overprescribing of opioids. ACOM has been collaborating for the last several months with the International Association of Injury and Accident Boards and Commissions on developing model legislation and regulations with respect to the use of opioids in the workers' compensation system. This draft legislation and draft regulation is going through final review process. At the point that it is finalized, then ACOM may participate in a process for outreach to other stakeholders to actually build some momentum for this model legislation and model regulation. In addition, ACOM has been very involved with FDA and CDC on issues related to opioids. We've also been very involved on Capitol Hill with some pending legislation that looks at the use of opioids. Another issue is what's called the Preventive Health Savings Act. This is legislation that was introduced a short time ago, and it will be reintroduced next year in the Congress. One of the problems we run into when we go to Congress and say that Congress should invest additional funds in preventive medicine and preventive health is Congress, under a quirk in the Budget Act, cannot look at the out-year benefits that might result from prevention. They're limited to what's called a 10-year window. So if you look at, say, a 35-year-old male, and you say that if that 35-year-old male were to participate in a employer wellness program, by the time that individual is 50, he will have been healthier and less of a drain on the health care system. That's a 15-year period, and Congress can't look at that. That's why during the Affordable Care Act, we were rebuffed several times by what's known as the Congressional Budget Office in the White House Office of Management and Budget, when we argued for additional preventive programs. The response always was there was no way to quantify the benefit of prevention. So the Preventive Health Savings Act that is sponsored by Representative Michael Burgess from Texas, who is also a physician, would be a major step forward in allowing Congress to weigh the value of prevention when they're considering legislation. Electronic health records, the key provision with respect to electronic health records is the use of the meaningful use standard. And meaningful use standard really goes to what should be required in an electronic health record, what is meaningful, where is there a potential benefit both to the provider and to the health system. Stage 3 of meaningful use was just proposed by the Department of Health and Human Services within the last couple of weeks. Stage 3 will help transition to a more specific focus on patient and family-centric medicine. To be considered for Stage 3, the objective needs to support new models of care, address additional health priorities, etc. The draft recommendation in Stage 3 includes capturing occupational and industry codes. This is something that ACOEM has worked in collaboration with NIOSH on to make sure that the electronic health record at a minimum captures what it is the individual does for a living and what industry that individual is engaged in. ACOEM has also sent to HHS a white paper on other issues with respect to occupation and issues that need to be incorporated into the electronic health record. We are now working on putting together comments on Stage 3 of the meaningful use standard. NIOSH and OSHA. Funding for NIOSH will continue to be an issue going into 2013. This includes funding for NIOSH's research programs and for the education research centers. The NIOSH budget is always in jeopardy. There is a group that ACOEM is part of here in Washington, D.C. It's called the Friends of NIOSH. We work with others to ensure that the NIOSH mission is allowed to go forward and the mission is satisfactorily funded. In addition to funding, one of the things that we are looking at, and this is in response to a request from Capitol Hill, is where NIOSH best should be placed within the federal government structure. It's no secret that NIOSH enjoys a very rocky relationship with the Centers for Disease Control and Prevention, where it's presently housed. That relationship seems to have worsened in the last several months. CDC effectively closed down 2 of the NIOSH research facilities simply by refusing to renew leases on facilities. One of those facilities is up in the state of Washington. Another one is on the East Coast that deals with mining. So that relationship seems to be getting worse rather than better. For that reason, ACOM and others are going to be asked to sit down and make a recommendation as to where NIOSH could be better suited. Should NIOSH operate as an independent agency, such as ARC does underneath the HHS umbrella? Should NIOSH be moved to the Department of Labor, etc.? So that'll be one of the issues that we'll be looking at in 2013. OSHA, on the standard side, OSHA is one of OSHA's priorities. Assistant Secretary David Michael, who is the director of OSHA, will be looking at what's called the I2P2 standard. This is the Injury and Illness Prevention and Protection standard. This will be a priority for OSHA in 2013. OSHA will also be taking another look at permissible exposure limits, the PELs. This has been a struggle for OSHA for many years on how to update the permissible exposure limits. They will again tackle this issue in 2013. Occupational exposure to infectious diseases. It will be may be a priority for OSHA in 2013. There was a public meeting on a potential standard more than a year ago. OSHA's activity on an infectious disease standard slowed down during 2012. I would expect it to pick back up in 2013. Another issue is the occupational exposure to silica. There is a standard for silica exposure that has been sitting for final review at the White House Office of Management and Budget for more than a year now. We are hopeful that the White House Office of Management and Budget will release this silica rule in the next few months, and once that happens, it would be proposed in the Federal Register as a proposed rule. Unfortunately, the OSHA standards-making process, as you all know, is a very, very cumbersome, time-consuming process. So we would not expect any of these standards to become the law of the land in the near term. I want to talk to you a bit about accountable care organizations and the patient-centered medical home and the role of OEM in these new delivery models. NCQA has a specialty practice recognition program. An occupational medical clinic had participated in a pilot study as part of the NCQA proposal. We're hopefully optimistic that NCQA will incorporate an occupational medicine model or module into their specialty practice recognition program that is very much patterned after the patient-centered medical home model. With respect to the patient-centered medical home, ACOM is an active member of the Patient-Centered Primary Care Collaborative. ACOM members are leaders in the collaborative. The collaborative will become more engaged in 2013. With respect to accountable care organizations, ACOM did publish a white paper on the role of OEM in accountable care organizations. We are now actively engaged, ACOM is now actively engaged in reaching out to others to talk about strategies for integrating OEM into accountable care organizations. It is a slow process, but I think ACOM is working diligently and moving forward on it. This is my contact information. Part of my role for ACOM is to be available to its members to answer your questions, to provide information to the extent that I can. With that, I will turn it back over to, to the operator to see if we have any questions out there. Thank you very much for your attention.
We'll now begin the question and answer session. If you have a question, please press star then one on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or hash key. There will be a delay before the first question is announced. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star then 1 on your touch-tone phone. Standing by for questions. Jennifer McCarthy is online with a question.
Hi. Pat, can you elaborate on the wellness increase in incentive for employees? You said it was going from 20% to 30%.
Right.
What exactly do you mean? Do you mean that's what they can claim as tax deductible?
No, this is against the health insurance premium. So if the total, say the combination of the employer's contribution and the employee's contribution for individual coverage was $6,000 a year. Under current law, if an individual participates in a health contingent wellness program, 20% of that $6,000 could be refunded back to the employee. When I say refund, it could be in the way of a reward, a cash incentive, whatever it might be. The new law, the Affordable Care Act, raises that from 20% to 30%. So again, using the $6,000 example, you could provide a reward back to the employee now of $1,800.
So it gives employers more money to incentivize their workforce.
Right.
Okay, thank you very much.
Mm-hmm.
Once again, if you have a question, please press star then 1 on your touch-tone phone. And I'm showing no questions at this time.
Well, thank you for participating in the public policy briefing, and the recording of Pat O'Connor's presentation will be in the members-only IDEA Marketplace later on today or tomorrow morning. This concludes the public policy briefing, and thank you again, and have a happy holidays.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.